Okay, hello everybody. Welcome to our 14th journal club, online journal club. Today we are going to discuss about a very important topic. Thank you very much for joining us.
Can I try to share again one time?
Yes, please go ahead, please.
Yes,
great. Thank you very much. Dr. Ali Munir Saheb is going to present the article and critically appraise it. We are also waiting for the authors to join us.
Hello.
Hello, Professor Cho. How are you?
Yeah, I'm good. Thank
Thanks
you.
for joining us. I know it is very late in Korea. Thank you very much for staying awake and joining us for our journal club.
Yeah, my pleasure. It's 10 o'clock, but I'm okay.
All right. Oh, it's good. Hello, Professor Jung.
Hi.
Thanks for joining. So we make both of you co-hosts in case that during the discussion, you want actually to share anything with audience. Thank you very much.
Okay, I really appreciate your invitation.
You're more than welcome. You're more than welcome. This platform is very popular these days because endodontists around the world join us and discuss the hot topics published in Journal of Endodontics, International Endodontic Journals, and other prestigious journals. Hello, Hassam. Thank you very much for joining us. I believe Hassam is joining us from Denmark. Am I right, Hassam? Hassam, I think you need to unmute yourself. Then we can hear you better. Hassam, we cannot hear you. You're still mute. Okay, we are still waiting for 2 minutes to officially start our program.
Okay.
Okay, hello everybody. Thank you very much for joining us. We have Professor Kim, the president of APEC. So I'm going to, without any spending anything else, asking him to start officially our session. Especially, we have two very important authors from same country. Professor Kim, please go ahead. Professor Kim, please unmute yourself. Yes, we can hear you now.
Sorry about that. Yeah. it's a special day for me actually. So today is the what number is this 18th OJC? How many times we have done already?
14th.
14th. Okay. So
Yes,
we
it
have
is the
done already
14th session
times.
of our online journal club.
Yeah, it's quite a special day today because the speaker is from Korea, my country, and the president of Korean Academy of Endodontics is also here, Dr. Professor Jung. So I'm
Wow.
very happy to see them here. So yeah, it will be a good chance to talk about the Korean research, endo research. So special, the speaker, Dr. Jo, is very special researcher here, young researcher in Korea. So I'm very proud of him. So I'm very happy today. So also Dr. Sanjay Migrani is also here. He's the chair of the education committee of the APEC. So he will give some good comments. Thank you very much.
Thank you very much, Professor Kim, always from your support. And we are very happy to have you with us today as well. Thank you very much, Professor Jung and Professor Choi, for accepting our invitation.
My pleasure. Thank you.
Professor Sanjay Miglani is the head of the Educational Committee of APEC, Asian Pacific Endodontic Confederation, that this program is based on a contract between Tehran University of Medical Sciences, which I am affiliated to. I'm also the consular of Iran in APEC, and we are all close friends with Sanjay and Kim, and all of us are aiming to improve our endodontic knowledge by this type of discussion. Professor Sanjay Miglani, the head of the Educational Committee, please go ahead.
Thank you, Dr. Nikufar. I think you made it sure that you brought us closer during this pandemic by organizing this journal clubs. And I'm really thankful on behalf of the Education Committee of APEC for doing such a wonderful job. And under the patronage of our president, Dr. Henry Kim, I think APEC is looking forward to have more journal clubs under your leadership. And my best wishes to the speakers and all the participants.
Thank you very much. And as all of you know that, we have all participants from around the world. We have Professor Al-Hawaizi from Iraq. We have Professor Viresh Chopra from Oman. And also we have Hassam from Netherlands, Professor Mima Ahmadi, a lot of people from India, from Iran, from around the world, from Korea, everywhere. And I think we have Miguel with us from Portugal as well. So we have a lot of people from around the world. This is amazing. This is amazing. This is an amazing platform to have everybody, all of us together. And the most important thing today is we have Professor Jung with us. And he is also the president of the Korean Endodontic Association, and also I think one of the very important and effective researcher in fields of endodontics that we are going to discuss with each other. So before we go ahead, I'm going to ask Professor Jung to give us an introduction, and we will carry on. Professor Jung, please.
Thank you very much, Dr. Nikufar. I'm very happy to be here with you, and I hope today's discussion will be very helpful to everyone. Thank you again.
Thank you very much. And sorry if during the discussion, we are going to discuss a lot of things and very direct questions. So this is a very scientific platform. So we put all the authors in a very hot chair asking difficult questions. This is the important part of this type of online journal club, which is very informative for our young fellows as well. Before we go ahead, I'm going to ask Professor Al-Hawaizi, the president of Iraqi Association of Endodontics, to give us an introduction. Professor Al-Hawaizi.
Hello. It's very good that we see each other again. I really thank you very much for all this effort and all the topics. Really, they are hot spots in endodontics. I was very flattered to read it and to read the article. And I'm very, very eager to to see the discussion and see the outcome. Thank you very much.
Thank you. And the reason that I'm asking you to give us this introduction because our appraiser today is from Iraq, Dr. Ali Monir Saheb. So Dr. Ali Monir, I think I don't keep you waiting. So please go ahead and share your presentation with us. Ali is going to give us a very short and quick presentation and summarize the article for all the participants. And then he's going to ask his own questions from authors and also other participants. If they have any question, they also show their hands by raising their hands electronically, and they can unmute themselves and ask their question directly from the authors. Thank you very much, everybody. Let's do it. Ali, please.
Thank you so much for giving me this opportunity to discuss this article. I'm going to share. First of all, I would like to welcome you all to join us for the 14th APEC Online Endodontic Journal Club. Today was the second anniversary of death of Dr. Ashufta. I know Dr. Ashufta for a short time, for 3 years. Dr. Ashufta was a great man. He served the TUMS and helped all the students in the TUMS. Can you hear me very well?
Yes, yes, please go ahead.
Okay. This is the poster of the 14 APEC. And the moderator, Dr. Kofer, the appraiser was me, and the author from the Korea. This is the face of the article, which is the clinical efficacy of the sealer-based obturation using calcium silicate sealer, a randomized clinical trial. This randomized clinical trial was compared the clinical efficacy and outcome of the sealer-based obturation technique with the calcium silicate sealer with the continuous wave of condensation technique with the resin-based sealer. The main finding of the article was that the sealer-based obturation technique using the endoseal could be a possible alternative to the continuous wave of condensation using the AH+. The second finding was the sealer extrusion and post-operative pain were found to negatively impact the prognosis of the endodontic treatment. As introduction for the article, for the AH+ sealer, the AH+ sealer have a short setting time with the 8 hours, not released formaldehyde upon setting when compared to the AH26, which consider a biocompatible, have a half solubility when compared with the AH26, not staining with the AH+, consider a dimensionally stable because of the very low shrinkage, and have a good adhesion to dentine and cataperca, and this increase if the EDTA is applied before the sealing of the canal. Have also the high radio opacity because they use the calcium tungsten and zirconium oxide. This article have physiochemical properties and cytocompatibility of the newly developed calcium silicate-based sealer, and I have a comparison between them. Regarding the radio opacity of the sealer used in this article, here we can see the different sealer used with the AH+ have the best radio opacity when compared with them. Other thing, as you can see here, when compared the AH+ with the endoseal, regarding the flow, the setting time, and the radio opacity, also we can see here that the radio opacity was the best for the AH+. Regarding the stability, dimensional stability of the different sealer, here we can see that the AH+ have near the same with the endoseal sealer. For the method of this study was a randomized controlled clinical trial. The study was approved by the Institutional Review Board of UNC University in the Korea. The patients were enrolled from the outside clinic of the Department of Conservative Dentistry in the UNC University in Korea between the April and September 2018. The inclusion criteria and exclusion criteria. The inclusion, all the patients with the fully formed abscess requiring that root canal therapy. Also, all older patients older than 18 years, patients should be with a good health, while the exclusion criteria included the patients who were unable to communicate their symptoms, tooth affected by cracks, severe periodontal bone. The root canal was not negotiable within 2 millimeters of the radiographic apex. The tooth was not ready for the root canal at the next visit. Here I would like to ask the author regarding the exclusion criteria. All the patient was treated in just 2 visits or more than 2 visits?
Okay, any of authors, please go ahead.
Dr. Choi, it's your turn.
Yeah, usually most of patients actually at least 2 visits. Okay.
Okay.
Yeah.
And what was the reason for that, Professor Jung? Because these days we believe we can finish the root canal treatment in 1 visit. Was there any special aim for doing that in 2 visits for this particular study?
Nothing special, but in this study, at first day, we finished the instrumentation, and next time we checked the condition of the patient. If there was no pain or no symptom, then we will ask the patient to invite our study. So actually, so therefore we need at least 2 visits.
Understand. That means you haven't selected your cases in the first sessions. You just finished the first session. If there was no pain in the second appointment, you divide them to 2 groups. Okay, understand.
Also, another thing, did you exclude that cases like with the procedural error or just with these exclusion criteria, like within 2 millimeter, not negotiable?
Oh,
Okay,
so the question is, if the case has got some sort of accident or calcification in the apical part, for example, or any other accidental errors during the treatment, you exclude them as well?
Yes.
Okay,
Yes,
so just
I will answer
the
for the
cases
question.
that they selected are straightforward cases. Am I right?
I'm sorry?
So you just select the straightforward cases that
Yes.
you were able to treat them
At the time of the operation, the patient didn't have any problem. Okay.
Okay.
Okay, I will answer for the question. Okay, we try to see the effects of only obturation technique and sealer. So we wanted to remove other possible affecting or distracting factors.
Yes, yes. That I think this is a very good description, because especially when we are looking for the post-operative pain of just obturation, it is a very good design for a study to separate the preparation from the obturation. I do agree with you. I think Dr. Mimamedi from Netherlands, he has got some idea. Hassan, please go ahead. Ask your question, please.
Hello, everybody. But I have a question about this inclusion criteria. So if you excluded those cases, so what did happen to those cases? Did you finish the root canal treatment or not? And if yes, did you obturate these root canals? And if you obturated, which technique?
So you're speaking about the excluded cases,
Yes.
Hassan, am I right? Okay. Dr. Cho or Professor
Yeah.
Jung, any of you, please go ahead.
Yeah, we proceeded the root canal treatment as usual, but we excluded from this study.
So when you say you excluded from the study, that means you excluded from the number of samples, or you didn't include them because of that problem. Can I say such a thing? You haven't even include them in the first session. It's not like lost cases. So it hasn't got any problem for you. Am I right?
Right, exactly.
Okay, good. So I think, Hassan, this is not going to make a problem, because if you don't include any case, based on whatever you decide to do, as far as you are consistent, I think that is enough. So this part of the methodology, I think, is right and hasn't got any problem, because they want actually not to have any co-funding variables, which preparation may have a confounding variable sometimes. So they decide actually not to include one visit cases in this study, which is fine. Although these days we prefer actually to do our cases in one visit, but because of the sake of the study, I think they did such a thing. Dr. Cho, is it what you tried to say? Am I right?
Yeah, it's exactly right. And we try to set included cases at the same condition.
Exactly.
Yeah, thank
Thank you. Thank you very much. Ali, please.
Sorry. The teeth were treated by 6 dentists, 5 postgraduates, resident, and 1 professor. And all procedures were performed over at least 2 visits. All endodontic procedures were performed under the operating microscope.
Ali, before you
Yes.
go, I have a question. And actually, I have received this question from some audience. The question is, usually the operators must be similar to each other, and their skill should be very similar, and they should be calibrated very similar to each other. But obviously, comparing 5 postgraduate residents to 1 professor and their skills that a professor comparing to residents may have, it may have some effect on the data and make it a bit inconsistent. Professor Jung, why you add up the cases of 1 professor to 5 postgraduate residents?
Because we at that time, we don't have much time. We need to have a more patient. So we add the practice.
Yeah, but it may be
Yeah.
open to bias and inconsistency. That is the question.
Actually, that's the problem. But at that time, we don't have much time. So we must finish our clinical study at the limited time. So that's
Yep,
the problem.
I know that doing clinical trials is very difficult job. I can understand that. So have you tried statistically to separate the result from each other? For example, just look at the result of the professor comparing to resident and find any discrepancy between them? Because in that case, you may also mention that in the article that there was actually an inconsistency between the cases. Have you done any statistical analysis on that?
No.
Okay, I think that can be a big question. That can be a big question. Okay, let's move on.
The first visit, they give a local anesthesia and the rubber dam isolation. The access opening was made. The working length was determined using the electronic extricator. The canal were prepared using the operator preferred rotary instrument. Here I have to ask the author regarding the operator preferred rotary instrument. Was this will affect the standardization of the method for this study when the different operator using different rotary instrument?
Yes, that's a good question. We use 2 or 3 kinds of rotary system. And as I know, the rotate gold is the most preferred system. So I think most of the cases, including this study, they use rotate gold.
So why you did not try to make this for all the cases, treat or prepare all the canal with the same system?
Yeah, that's a good point. I think we controlled in this study the rotary system. It would be more controlled study. That's good point. Unfortunately, we didn't.
Because like different instrumentation will make for the flowability of the sealer, for different things for the sealer.
I'm sorry?
When we use different procedure, instrumentation procedure or different rotary instruments, so this will affect like for the flowability of the sealer in the dentina tubules. So will affect that the characteristic of the sealer.
So the question is, if you, for example, enlarge the canal because you said operators prefer the rotary instrument, so maybe one operator tried to do something and then they use another one. So the size of the apical preparation is not similar. So the amount and the volume of the sealer that were used is different in different cases. Therefore, it can be also open to inconsistency. I think Professor Al-Hawaizi wants to add a comment. Professor Al-Hawaizi, please.
Yes, I totally agree with Dr. Ali. I think that
I think the connection, Dr. Al-Hawaizi, we cannot hear you very well. Can you repeat, please? I think the connection of Professor Al-Hawaizi wasn't good.
Sorry. Hello.
Hello, Professor Al-Hawaizi, please repeat. Please unmute yourself and repeat. Yes, please.
The rotary systems that you have used, were they all rotation mode or reciprocation? Because, you know, it makes a difference.
Yeah, so that is another thing. So I think, Professor Jung, if you put all these questions together, because there are other comments as well, and because of sake of the time, I want to actually do that very quick. The question now is based on why you didn't standardize or make it consistent for all the cases, all the operators to follow same guideline for the preparation. So this is the first question. I think Professor Kim wants to add something as well. And we have Professor Vatanpur wants to add something as well. Professor Kim, please go ahead.
Yes, there's some 2 points about the protocols, the materials or methods. So why the case is not controlled for the instrumentation or something like that. So as I wrote in the chat box, the authors actually wanted to see the effect from the different sealers and obturation techniques. So they just finished the first protocol for the instrumentation and other procedure just before the root canal obturation time. So there is no need to control that until that time. Just they gathered the patient, the cases just before the obturation procedures. So that is important point. So we don't need to consider what instrument was used, what kind of condition before obturation. That is an important point of this study. I think so. How about that, Dr. Cho? Am I correct?
Yeah. And our protocol is actually the minimum apical size is prototype called F2 size. Most of the doctors use the final file is the prototype F2. So the taper and prep amount is maybe similar, but that may affect the result. But at the time of obturation, we randomize the case. So this impact may not be significant.
All right, so you divide them randomly and you didn't know that which technique that they use for the preparation. So according to the explanation and description by Professor Kim, I think we need to emphasize on this part that I also mentioned that at the first part, that in this study, the preparation is not a part of the case selection, just the obturation is that. So let's see what Dr. Vatanpur wants to add. Dr. Vatanpur, please go ahead. And then Hesam will ask his question.
Okay. Hello, everybody. I want to ask a question about matching in your study. This study really is a good study and good clinical trial, but I think according to the consort statement, we need to match our study groups. For example, you had different operators, different obturation method, different also condition of the cases, pre-operative pain, and so on. And I think it was better that you use stratified randomization to match your samples between two groups. I want to know what's your opinion about this matter.
Okay, Professor Jung or Dr. Cho, please.
Yes, you're talking is all right. I agree with that, but to fulfill the requirement you set, maybe the sample size would have been more than 1,000. So I think you are right, but in real situation, we can't help choosing all the variables in the same condition. So, but within the limitation of the study system, we try to make the best conclusion, and if yeah, I accept the points you said about the protocol, but that's our best, I said.
Okay, but I think the most important thing is to separate these two issues from each other. What they try in this study and what I understand from the explanation of Professor Kim and Professor Jung, the important thing is it doesn't matter that which technique that we use to prepare the canal, and then when they have a lot of cases that they prepare their canals. They select and randomize their cases and try to match them based on that by randomization technique, which we will discuss next. Then we put them in two separate just for the sake of evaluating the obturation technique. So let's see what Hesam wants to add. Hesam, please.
I think in these studies, if we only randomize the cases, it doesn't solve the problem, because we may have all the cases which may finish with, for example, protaper F2. They are in one group, and the cases which are prepared differently, for example, reciproc R40, which is completely different enlargement, different tapering, they are maybe in other groups. So in this kind of a study, we need to do randomized control randomized. So we need to have a control on randomization. I mean, if we only randomize, we don't know how it goes.
Okay, Dr. Jung.
I'm sorry, I cannot understand what the question is.
What Hesam trying to say, Hesam say that randomization is not going to help. We need to standardize the size of the apical preparation and the type of preparation, because as Professor Al-Hawezi also mentioned, if, for example, one group use reciprocation and another one use another rotary system, it has also some effect, may have some effect on the result as well.
Or we can control randomize. So we can randomize with control.
So randomization itself is not enough, what Hesam tried to say. He said that we need to standardize the cases according to the technique that we want to use. You already mentioned that you use F2 protaper for all cases. Am I right?
Most of the cases.
Most of the cases. So that can be open to the question. That can be open to this question. Okay, let's see what Miguel wants to add. Miguel, please go ahead. Unmute yourself, please.
Hello, thank you for giving the opportunity to talk in this session.
Thank you very much for joining us from Portugal. Thank you.
I think we must differentiate two things. For the internal validity of the study, to have different kinds of rotaries, it is something critical. But for the external validity, for what other clinicians' message can be taken from this study, what, like myself or other practitioners, can learn from this study, the external validity of this study is not jeopardized by having different root canal rotary systems, because in every part of the world we are using different systems. So maybe in a pragmatical point of view, this will not be critical. I think if you look at this purely from the point of view of the science, for the internal validity, it is critical, but for the conclusions for the clinicians will not be jeopardized by this.
Thank you very much, Miguel. And I believe Miguel is expert in the methodology because he is now leading a very, very amazing and very, very big group of the researchers in endodontics. So I think his comment is very, very precious. Thank you very much, Miguel. So the important thing now, if we want to put together all these comments, means that if we are looking for external validity and the pragmatic part, this study is going to help us. But if not, if we are looking for the details and we want to have a very precise result without any inconsistency, then these questions can be right. So I think we leave it to the participants to make sure that in which way they prefer actually to get to the conclusion. Thank you very much, Miguel, for your contribution. Okay, Ali, please carry on if there isn't any other comments. Ali, please.
Yes, in the continuation of the treatment, after that, The master apical size was determined by the operator on the basis of the initial apical file size. The canals were irrigated with the 2.5 sodium hypochlorite. Passive ultrasonic irrigation was performed to remove the severe contamination. In the second visit, the patients were invited to participate in the study if there were no or only minor signs and symptoms. At the next visit, an assistant blinded to the study objective created a computer-generated list of random numbers using the sealed envelope website with the one-to-one allocation and using random block sizes of 6. The two groups was the first group, the sealer-based obturation with the endoseal. The endoseal was dispensed into the middle third of the canal. A single catabarca cone was inserted in the canal following an up-down motion 3 times to allow the sealer to penetrate better. For wide canals, 1 or 2 additional catabarca cones were inserted to optimize the sealing. Also here, there is a question regarding the obturation. If we use like additional catabarca, so we will have lateral condensation method. Is there any difference between the obturation groups or not?
Not right. There is no, I'm sorry, my English
So
bad. Yeah.
You mentioned
We just put
the sorry, continue please.
We just put the accessory the gutter cone, not compact lateral compaction.
So you say that you separate like the instrumentation from the obturation, the standardized in the obturation method. Here we can see different, not a standardization for the obturation regarding the first group.
Mm-hmm.
Okay, so did you have an explanation for that or not?
Ali, can you repeat your question slowly, please?
Yes, okay. The author said he separated the instrumentation procedure from the obturation procedure, and he tried to standardize the obturation. When the author used different obturation, like with the lateral condensation, he added some 1 or 2 catabarca. Other groups have just single cone catabarca. So there is inconsistency between the groups. Am I right for that?
So, Dr. Jung, please explain why you didn't standardize the number of guttapercha or volume of the sealer or volume of the guttapercha in the obturation part. Obviously, this time, because you are going to obturate and compare the obturation technique, this part is very delicate and must be standardized. The question is that.
Most of the case, doctor use the single cone, but in some case, the doctor, it's the doctor's decision to use the 1 or 2 guttapercha use. So if the canal is too wide, the doctor decide to the 1 or 2 additional guttapercha.
Then do you think it can be a source of the discrepancy again in the result? That can be a source of the bias.
That may be a problem, but at that time we don't have much consideration on that, so that's the problem.
Yeah, maybe in the future, if other colleagues try to design such a study, they may standardize the preparation technique by using just one similar technique in all cases and try to make all the canals very similar, because the volume of the sealer may have some effect on the post-operation. may have some effect on the pain, may have some effect on other variables. So this is the question that Dr. Ali Munir tried to raise. Thank you, Ali. Please carry on.
The other question, if I can, did you use the same amount of the sealer in all the canals or not?
Pardon?
Ali, again?
Did you use or insert the same amount of the sealer in each canal? Because this affects the sealer extrusion.
Similar question that I asked Dr. Jung. The question is, okay, the number of gutta percha is different. Obviously, the amount or the volume of the sealer in each case is not similar to another one. Therefore, it can be open to another question that the amount of the sealer may increase the possibility of post-operative pain as well. We need again to think about how to standardize such a things in a clinical trial. The question is that, have you tried to standardize, for example, to say that 0.2 ml of the sealer must be used in each case? Have you tried such a thing or not? You just leave it free for the operators to do.
It's up to the operators' decision.
Okay. Yeah, so that is the question. That is, I think Professor Jung and Dr. Choi, the most important thing is in this type of studies, when we run a clinical trial, we need to be very careful about all this standardization. Otherwise, I personally think this study is an amazing study and can be done like a prospective cohort study rather than a clinical trial. For example, if we go back and look at the publication by Professor Kim around 10 years ago about the outcome, she published, I think, around 10 articles in London. And what they did by Professor Gulabiwala and Dr. I think there is a team over there in the Eastman University in London. They try to show that whatever the residents they do, they just record it as a cohort study comparing to a clinical trial. Because when we run a clinical trial, we need to be very careful about the standardization. I believe in that. What do you think? Do you think your study has enough control to show us the result like that or not?
Actually, these days, we are doing a similar clinical study. So at this time, we take care of the many befores at that time. Yeah.
Good. Thank you. I think this is very useful for our young fellows when they want to design one study. Please accept our apology if we are very harsh, asking a lot of questions. But the goal of this session is that. Please accept our apology. This is just the academic discussion, not anything else.
Okay, I want to say something.
Please.
Yeah, it's a clinical study, clinical trial, but also we have to make the best results for the patients. So I think standardization is very important for clinical trial, clinical study, for research. But in clinics for the patients, we have to the best procedure to fit in that tooth. So I want to ask something. There are the teeth included in this study are various, that different shape, different amount of the space, but you're the doctors asking us to standardize the size of the muscle cone or sealer. I think it's good for the study, but for the patient, for the canal, for the tooth, we have to choose the most fitted master cone, and we put the sealer in the rest area. That's our treatment. I think if we go back before the study design, I think it would not so easy.
I do agree with you, Dr. Cho. Doing a clinical trial is very, very difficult. And the reason that I suggest changing such a things to a cohort study or prospective cohort study by recording all the variables is that, because if you have hundreds of cases with different techniques, doing whatever you are doing that for the sake of the treatment of your patient, write it down and evaluate it, just that. You don't need actually to do any intervention. This is very important. And also in the chat box, Hesam mentioned that from material science point of view, this technique name is actually sealer, is not a sealer-based obturation. It is actually a gutta-percha-based obturation that we use sealer. This is a point. So when you run a study, a cohort study, you can do whatever you are doing and whatever you prefer and your doctor prefer to do, and then just write it down and record it. Then you have a lot of variable. A statistician can help you to sort it out. So let's say what Dr. Hajar wants to say. Dr. Hajar, please introduce yourself and please say us your comment. Dr. Hajar.
Hi all, it's my pleasure to meet you all today. I am Dr. Hajar Mohammed Abdul Hamid, the head of Endodontic department of MTI University in Egypt.
Oh, thank you very much for joining us from Egypt. That's amazing. Please go ahead, Dr. Hajar.
I heard all the comments from the doctors, but I have two comments. First of all, as the doctor said, he didn't standardize the tooth or selected tooth. So the size of the canals is different. So when we said that all of them used pro taper, or many of them used pro taper to F2, I don't think that this matches in central tooth. So I think that the many variables present in this study, in case of lateral condensation or single cone technique, there is a difference, as you said, doctor, in the amount of the sealer. So the outcome will be differing. We have to standardize an issue. We cannot separate the cleaning and shaping from the obturation. It's a system. Everything is based on the previous step. Like the doctor said before, they exclude some patients with signs and symptoms, so they have to exclude also another variables. Why they didn't exclude? They just exclude the signs and symptoms only.
Okay, Dr. Hajar, thank you very much for your comment. But before Dr. Jung and Dr. Cho is going to answer your comment, I'm going to ask Dr. Viresh Chopra to give us his comment. Viresh, please go ahead. Although your name here is not your name, it is Alia, but I think it is not you.
Yeah, she is my daughter and she has hijacked every account of mine.
Okay, Viresh, please go ahead.
Okay. First of all, thank you for the invite at this journal club.
Sorry, Viresh, before you go ahead, let me introduce Viresh. Viresh is the author of the Retreatment Endodontic book, so he knows a lot about the clinical part as well as the scientific part, because he is running a lot of study about calcium silicate cement-based material. Dr. Chopra, please.
Thank you so much, Prof. Nekofar, for this nice introduction. First of all, I would like to congratulate the authors for this publication. It is, as everybody is saying, it is not an easy job to do a clinical trial, because the clinical trial is lab study is governed by the operator. Clinical trial is governed by the patients, right? However, standardization, I feel, is really important. But what I feel personally is the difference with the standardization in clinical trial is like, you can fix the instrumentation technique, you can fix the standardize the type of instruments used. However, the amount of sealer used is very difficult to standardize, because it depends upon the dimension of each canal, which is not measurable in a clinical trial most of the times, right? I feel if you want to standardize the cases in a clinical trial and randomize them in different groups, it should be done after master cone selection, right? Once the master cone fit is seen, that F2, for example, if we are using ProTaper Gold and F2 fits in all cases, that is when we can randomize the clinical cases, not at the time of, means not after post instrumentation, but post master cone selection. I feel that would be a much better approach. Personally, this is what I feel, where we can avoid a lot of questions which are raised here at this point of time. And a second observation was, no offense to anybody, but when I read this topic a few months back, it was published, a sealer-based obturation, I was inquisitive, because I felt that this is a coneless obturation, because I have never heard of any obturation which is not sealer-based, right? But I salute the creativity of the authors to present, in a different way. Every obturation is sealer based, but what I felt from the title was that gutta percha has not been used, and only sealer has been used, and means that is so. My first question was that what made authors title it as sealer based, because no offense, I just want to know the thinking behind it. Why I want to know is, you might come to know after a few years, because I'm doing a study which is something like that. So these are my comments.
Thank you very much, Viresh. I think before we ask Professor Zargar to give us her comment, I'm going to ask Professor Jung and Dr. Cho to answer the comments. First by Dr. Hajar from Egypt. That was again about the standardization, although we have received the explanation and description by Dr. Cho about the difficulty of that, and the suggestion by Dr. Chopra to have some sort of suggestion for how to standardize the case. So that is the first question. And the second question that was raised by Hessam and Viresh both is about the sealer-based obturation. What do you mean out of it? Because all the obturation are sealer-based, and when we say sealer-based, usually we should somehow address to gutta percha-free obturation when we say sealer-based. Please, Professor Jung or Dr. Cho.
Okay, I will answer for the question about sealer-based obturation. The key characteristic of this technique is the use of sealer, calcium silicate sealer, not just use of just single cone. And so it is totally different from traditional single cone technique using traditional sealers, which are hydrophobic, highly viscous, not flowable, something like that. We actually, there is an interesting story. We actually use single cone technique in the manuscript, but one of the reviewers asked us to change the term to sealer-based obturation. This term, so I looked through the PubMed, that this term first appeared in a clinical study last year, which was written by doctors of UPenn Group, University of Pennsylvania. And I remember Dr. Seung-Gu Kim in University of Pennsylvania used this term, Shiller-based endodontics, during his lecture in AAE annual meeting several years ago. So I think the reviewer who asked us to change the term might be from University of Pennsylvania. Anyway, we partly agree with the reviewer because it's different from the traditional single cone technique. So we agree with that. So we changed the term. That's my answer for the this terminology.
Okay, and I think you already answered the standardization issue as well. Okay, thank you very much. And I think Dr. Zagar is going to raise her question, and then Dr. Hessam has got something to say, and Dr. Kim sent some information and some description in chat box that I asked him to say it himself. Dr. Zagar, please.
Hi and warm greetings to everybody. And I should thank two authors of this article. I know that clinical trials are challenging tasks, 감사합니다. But I have a question about the title. I think that the clause clinical efficacy is a general clause. And I think there should be a better clause to use in this site. And according to my colleagues, Dr. Vatanpur, I wish to see a table compare the group tests about the confounding factors such as age, type of tooth, vitality, pre-op pain, and type of treatment. And I think if there is a table about this matter, many problems have omit because if there isn't a significant difference between groups, you can compare the group tests according to your outcome question. Thank you.
Thank you very much. So there are two questions. One is about the efficacy. What do you mean out of the efficacy in the title? And second is about why you didn't publish a table or put all the data related other co-founding variables, such as age or gender or other things that may have some effect, preoperative pain and other things.
Okay, I'll answer for the first question, efficacy. We aim to evaluate the two procedures in terms of clinical efficacy and outcome. Clinical efficacy means how well a treatment achieves its aim. So how well could indicate how fast, how not painful, how easily, something like that. So among them, we measured post-operative pain, how not painful, and obturation quality. That's my answer.
Mm-hmm. And about the publication of other variables such as age, gender, and other variables in a table in the publication. Why not?
The table two shows the variables.
Okay, Ali, can you show us the table 2 if you have it in your presentation, please? Because that can be the answer to question. I think Ali prepared, okay, table 1. So this is table 2. So Dr. Zagar, in table 2, you can see age, sex, tooth type, vitality, and other things. But the thing is, maybe they don't have any statistical effect on the result, I believe. Am I right, Dr. Jung?
Joe?
No.
So
we can see the significance of each factor, like age. We can see the significance in table 2. So age was insignificant based on loose criteria and also strict criteria.
Okay, Dr. Zagar.
Excuse me, I think you should compare the group tests according to these variables.
Ali, can you go back to the table, please, and keep it there, because we are now discussing about table 2. Dr. Zaka, can you repeat your question, please?
I think you should compare the two test groups according to these variables.
So when they show that there isn't any significant difference, or if there is a significant difference between them, it means that they compare them to each other. Am I right, Dr. Cho? You already compare each group based on these variables?
We randomly distributed to 2 groups. So
Okay.
I don't remember the exact distribution, but I believe that all the cases were distributed equally to the 2 groups of age.
Okay, so it's very similar to the one that Hesam suggested, to have some controlled randomization. Hesam, please add your comment.
I had again a comment about the sealer-based technique. So if you think that calcium silicate-based cement will lead to success in this obturation technique, why you didn't compare with the same technique with AH+? So because with AH+, you have a different technique of obturation.
So I think now the description by Dr. Kim can also help. Dr. Kim, please.
Yes, I have texted in the chat box. So the sealer-based technique is not so popular yet in the global society. So we need to think about the meaning of the sealer-based technique, as already Dr. Cho mentioned. But the sealer-based technique just use the pressure release technique. When conventionally, typically we use the pressure for the lateral condensation and vertical condensation. But in this sealer-based technique, we don't use any quite big pressure. Just put the sealer and 1 cone or 2 cone in the canal lumen. So there should be large amount of sealers in it. But in the pressure technique, like lateral condensation or vertical condensation, there's minimal sealer located under the 10%. I think maximum 5% around that. So that is the biggest difference between those two observation techniques. So in this study, as I understanding, just comparing those 2 techniques with pressure or pressure release and with large amount of sealer or least amount of sealers. One is the using the epoxy resin, AH+ is the conventional technique, and the sealer-based technique is like a new one. So there's main difference to compare this study from the author side and the other participant group tonight. So we need to focus for the main purpose of this study. So that is main issue, but you can read my comments in the chat box.
Okay, thank you. Thank you very much, Dr. Cho. The question that Dr. Miyadi, Dr. Hesam tried to set is why you didn't use same technique that Dr. Kim explained for AH+1, if it works.
I'm not sure I understood the question. So
Sam, can you repeat the question, please?
If we think that the sealer-based technique, the reason that it will be succeeded, it's because of the calcium silicate cement. So why we don't compare it with the same technique with different sealers? So I mean with AH+. So to have the same technique in both groups, only different sealer.
Because in AH+ group, Dr. Cho, you didn't use just the pressure-less technique, as Dr. Kim explained. So the point is, why in AH+ you didn't follow same methodology?
I think it's not right protocol to apply pressure release technique with H+, because it's hydrophobic. It cannot flow into the delicate structure in the canal. it's not right procedure. It's not recommended, I think. So
All right,
I
and you use AH plus just for the gold standard as a gold standard technique?
yeah, only with the compaction technique, not pressure release technique.
Essam, do you want to add anything?
No, but I think the name of the technique, so the sealer-based technique, because it's because some scientists, they have used the hydraulic technique, so it means to use the hydraulic cement. So I think it's not really sealer-based, because you have again gutta-percha as the base. And you mentioned in your study, when it's a large canal, you place gutta-percha, so laterally. So it means, again, the base will be gutta-percha and not the sealer.
Okay, I understand that. I agree. I agree
Okay.
that sealer-based obturation is the best term for this procedure. I totally agree with you, and we need to find the best term for these treatments from now.
Okay, thank you very much. Dr. Vatanpur, please.
Okay, I want to ask a question about the master cones that the authors used for obturation. Is the gutta-percha that you used was the single matched cone or only single cone or single tapered cone? And was the cone coated gutta-percha or not? This is my question. And also I have two comments about the title and about the table 2.
Okay, Dr. Vatanpur, before these two comments, let's them to answer this, please. Dr. Cho, the question is about the master cone. The master cone you choose, was it actually fitted, or how do you choose that? Oh, Dr. Jung, please.
In the case of the Pro-Taper Gold, the company provided the similar taper cone. We use them. And in most of the case, our resident and the professor have the corresponding cone, gutta-percha cones, to the master rotary file. So, is it helpful?
Yeah, so this is the fitted cone somehow.
Yeah.
Okay. Dr. Vatanpur, other comments, please.
About title, I think efficacy is a good word and clue for an ideal clinical trial. And I think this article is only about post-operative pain of these two types of obturation. And I think it was better that we used, for example, comparison of post-operative pain after use of these two groups. Because efficacy have different fields, and we should study about different matter, and then we claim that this system has more efficacy than the others. And about table 2, I think we should consider when we want to design the study about the confounding factors. For example, age, sex, and so on should be considered previously, and as I mentioned previously, should randomize stratifiedly between two groups, or it should be omitted or matched between two groups. And even in another table, the authors gave us insignificant difference between two groups. It was not logical for designing of this type of study. Really, this type of tables only is for confirmation of our claim that before this study, we considered that these confounding factors stratifiedly divided between the two groups. And in the table 2, I want also to emphasize that in table 2, only comparison is between level of each variable. For example, in age is a comparison between less than 50, more than 50. In the sex, between females and males in all of the samples, not between two main groups. Then I think it cannot confirm the matching of these variable between two groups. Thank you.
Okay, thank you very much. Professor Jung, Dr. Cho, do you want to add anything to these comments? Nothing? Okay, Dr. Chopra, Viresh, please.
Thank you for explaining the need of using sealer-based obturation, Professor John and Dr. Cho, because I totally agree, and this is a very vital point that you have raised, though it is away from this topic, that sometimes when we send the article manuscript for, to the journal, some reviewers want some typical terminology, right? And this is a very valid point, that terminology sometimes the authors have to do because the reviewer wants it to be done, and it is not basically fitting the this thing, but you have to fit the idea of the reviewer, because somewhere as authors who have really worked hard on preparing the manuscript, we want it to be accepted and published, right, rather than jumping these websites. So this is a very valid point, and I totally agree to this explanation that sometimes we don't want it, but it is not in our hands. We have to do that. Second thing is, I just wanted to say, like Dr. Hassam said, that sealer obturation technique should be standardized. That why didn't you compare AH plus? It is a very valid point that we cannot, when we are doing a lab study, we can standardize. We can stand because we are not harming anybody. Whereas when we are doing a clinical study, we should be using, rather not have to, we should be using standardized recommended techniques. Though we are comparing two different obturation techniques, but they are recommended, and all the, like for example, if we use AH plus, recommended is WVC technique. If we are using calcium silicate sealers, single cone has been recommended as one of the best techniques. So probably I agree with the authors that because here if we change the technique, this means ethically we are not doing good to the patient for only our research. So that standardization is very difficult to be done, and I would agree with Dr. Kim and Professor Kim and Dr. Chu that standardization is not possible, and ethically we have to do good to the patient. So recommended techniques should be used here. Thank you so much.
Thank you very much, Viresh. I think, Professor Jung, the nature of this type of discussion is to discuss about the details. And as Professor Viresh Chopra said, no offense, and please accept our apology if we ask a lot of questions from various aspects of view.
No problem.
Okay, thank you very much. Thank you very much. Professor Kim, please.
Yes, I just want to need some more comments about the technique using the bioceramic sealers. So one doctor asked that why the authors didn't try to use the AH plus sealer as a sealer-based technique. So one most important thing of the sealer property from those two sealers, one is epoxy resin, one is calcium silicate sealer. The epoxy resin sealers usually shrink as time goes on. But the calcium silicate sealer, it expands slightly. In the literature, it expands 0.2% after final setting. So we can use it, the bioceramic sealer, as a paste-based technique or sealer-based technique. But epoxy resin sealer is shrink, so it should be minimized. So the pressure technique we need, and the sealer should be constrained at least like under the 5%. But expanding property, it make possible to use sealer-based or paste-based technique. there is big difference for those two techniques. We should understand that point.
Thank you. Thank you very much. I think that was very, very fruitful discussion so far. So let's have a quick break and watch one of the video of our sponsor. Zohre, please go ahead and show one of this video, and we can stretch ourselves and have a quick break. Okay, thank you very much. Ali, please carry on, speak a bit quicker because of the sake of the time. We're almost out of the time.
Okay. While we are in the table 2, I want to ask a question here. Can you see?
Yes, please.
The author mentioned in the material and method, he included the patient that's seeking for the dental root canal therapy, but he didn't mention the retreatment or the initial treatment. So here we can see like necrotic, vital, and retreatment. So he mean that he used also the retreatment cases for this study, or just the initial treatment?
Okay, Dr. Choi, Professor Jung, please. The question is, you already add some retreatment cases as well. That can be again open to another discrepancy or non-standardization of the cases. What is your description? Please unmute yourself. Yes, please.
Yeah, we understand and accept the raised points, but we need more cases for this trial, and we set the very standardized condition just before inclusion. So I understand if we use only vital cases, this study would be much control study, and or if we use the necrotic cases only, it would be better. But we need more cases, and we included all the cases. But we set the starting point at the same, just before inclusion, just before obturation.
Okay, I think this is what we already discussed, that the trick that authors use in the design of this study can be very useful for other researchers as well, that if we cannot standardize everything, every variable, we may separate the preparation from the obturation and select our cases after finishing the preparation by any technique, including retreatment. Okay, Ali, thank you. Please carry on.
The second group, the alteration of the second group with the cadaver cones were coated with the AH plus sealer and inserted into the prepared root canal. The heated blagger used to cut and compact the master cone 4 to 5 millimeters short from the working length. The backfill of the canal were performed by the thermoplastic injection. For measuring the outcome variable of the post-operative pain, the patient recorded their pain from 0 to 10 using the numeric rating scale. The patient were required to report their pain level at the following time point at 4, 24, 48 hours after the obturation. Regarding the quality of the root canal obturation, two blinded and calibrated examiner evaluated the periapical radiographs taken immediately after root canal obturation in terms of the sealar extrusion, root filling voids, and the leveling of the root filling. The sealar extrusion and root filling were classified as either absent or present. The level of the root filling was recorded as adequate or long. Regarding the measuring of the healing outcome, the participants were recalled after at least 6 and radiographic clinical examination of the treated tooth was performed. The preoperative and recall radiographs of the root were each assigned using the periapical index score. The clinical examination included the presence and absence of pain, swelling, other symptoms, sinus tract, in addition to the functionality. Can I ask the author what he mean by the functionality?
Yeah.
Please. What do you mean out of functionality?
The tooth is functioning.
You mean a crown or just any technique that make it functional?
The patient had no pain on bite. And the patient can choose the food or something without pain.
All right. Okay.
Here you can see the periapical index score. 1, the normal periapical structure, periapical index is 2, bone structural change indicating but not pathognomonic of apical periodontitis. 3, bone structural change with the some mineral loss characteristic of the apical periodontitis. 4, well-defined apical radiolucency. 5, with the radiolucency that radiating. The author put some picture about the healing, healed, and diseased. The healed, he meant by the healed, the functional, asymptomatic with the periapical index score 2. The healing mean the teeth that are asymptomatic, functional with a decreased size on the radiographic radicular radiolucency. The disease, non-functional, symptomatic, that also the teeth with the periapical index 3. Also, he divided the result by the loose criteria, strict criteria. The loose criteria, the success include the healed and healing, while the failure include the failed cases. In the strict criteria, the success include just the healed, while the failure included the healing and failed cases. Here in the result, there is a 66 teeth showed no or mild pain, and 8 teeth showed moderate to severe pain after root canal obturation. Also here, I want to ask the author, the patient was 68 patients, while the teeth was that treated were 74 teeth. So how you manage that in the the post-operative pain? Did you treat when the patient have different teeth? Did you treat it at the same time or between time level between the 2 teeth?
Dr. Cho, Dr. Jung?
I'm sorry, I don't understand the question.
The question is between the number of teeth and number of patient. Obviously, the number of teeth is more than the number of patient as you showed in the table. The question is, you treat maybe more than one tooth in one patient. Is it right?
Right.
Okay, and so do you think it may have some effect on the post-operative pain as well? Because when you treat more than one case, one tooth in a patient, it may increase more pain for that patient. Was it in separate time or in same time?
Maybe
Usually
separate time.
Separate time. So it is like separate patient, not at same time. So good to describe such a things in the discussion sometimes as well. Thank you. Dr. Vatanpur, please raise your question very quickly. We are out of the time.
Okay, I have two questions about the post-operative pain. First, what was your policy ethically? What was your policy if the patients had severe pain, for example, after 4 hours? Did you exclude them or not? And the second one.
Oh, let's answer this question first. Professor John?
Okay.
We did not exclude the patient because of the pain.
But so if they have severe pain, what was your policy?
Maybe the patient took the analgesic, painkillers.
Mm-hmm.
Usually the painkiller will solve the problem.
Okay. Dr. Vatanpur, is there anything that you want, you have with this explanation?
I think this is a big matter in the study of post-operative pain because if, for example, in one groups, most of the patients used painkiller, there is a really significant difference between two groups. And I think in such a study, we should exclude these types of patients. And when we design this type of study, we should consider these lost to follow-up patients and to consider that it is, for example, possible several of patients will be excluded. Then because to control of our sample size, we should consider the sample size. I think this is a big matter. And the second question is why you don't use a quantitative scale for your pain. Only you use a numeric scale and you categorized it. We know that quantitative statistical analysis is more precise. You used numeric, then categorize in 4 levels, and in your statistical analysis, you mentioned that use chi-square. Chi-square is for only nominal variable.
Okay, Dr. Jung, I think this is very important in terms of methodology of pain measurement. Do you want to add anything to that, please?
Yeah, at that time, we don't have much consideration, but the numerical system is widely used to evaluate the pain severity. So we use the NRS system.
Yeah, but the problem is you categorize them after that. The numerical is sometimes more precise, but when you categorize it, you have to change the statistical analysis as well, as Dr. Vatanpur explained very well.
Frankly speaking, I cannot remember, but at that time, the sample size matters to evaluate the pain severity. So we just use the categorized system.
I think
okay. Yeah, please.
For statistical analysis, we with the chi-square and multiple regression, we need to categorize all the variables. So it is simple to explain, simple to analyze. I think that's why.
Yes,
can I
please.
Explain?
Yes, please.
I think it was better that you used quantitative test For example, repeated measure on ANOVA for different time point that you measure the pain, and also for regression, you could use linear regression because of the logistic regression. You use logistic regression because you consider your variable as a categorical variable.
Categorical.
Yeah, but we cannot manage other variables like numeric variables. So we have a lot of categorical variables, except for only one variable, which is pain. So in order to use only one statistical method, we need to convert all the variables to categorical.
Yes,
Okay.
but I think,
yeah, please, Dr. Vatanpur, please.
Yes, but I think it was better that you had several statistical analyses, one for categorical variable and another for quantitative variables also. And my other question is that you used chi-square test. Chi-square test is not also for categorical variable. It is only for nominal variable. It means that you consider that the patient have pain or not pain. In categorical, you consider 4 level of pain. Then you should use, for example, a Mann-Whitney test between 2 groups. But when you used Fisher exact test or chi-square test, it means that you consider your variable as a 2-level variable. And this can reduce extremely the precise of your test. And it may be that because of this matter, you have not significant difference between 2 groups. And also, we know that when you don't have statistical significant difference between 2 groups, it can be arise because of the 2 reasons. One, because of the lower sample size in the study, a low sample size in the study, and the another because of the real difference between 2 groups. And you should mention to the power of analysis in this study to confirm that your sample size was enough. Now I can claim that your sample size is was not enough, then the result is not reliable.
Dr.
Yes.
Choi, Professor Jung.
Yeah, I understand what you're saying, yeah, if the variable of pain is like a serial categorical, it's different from nominal. I understand that, and I'm not sure. I don't know. We can analyze the univariate analysis with serial variables, and then put the variable into the multiple regression or other regression. Is there? I don't know the right statistical analytic method for that, but if I find it would be better method for statistical analysis. Thank you.
Okay, thank you very much, Dr. Vatanpur, for your very precise and very, very informative comments. I think one of the main goal of this platform is to make our network larger and work together in the future. So we recommend collaborative studies in the future. Somebody like Dr. Mahdi Vatanpur can help a lot for designing the study. So we are now open to a lot of work together and collaboration, hopefully in the future. Thank you very much, Dr. Cho and Dr. Jung, for being with us and accepting our invitation for this discussion. Ali, I think we are out of time. We're already out of time, but if you can go to the conclusion and to the end part of the result, it can be very, very good. Thank you very much. try to finish it in 5 minutes.
Yes. Okay. The total success rate of the root canal treatment was 93 on the basis of the loose criteria. According to the restrictive criteria, the total success rate of the root canal treatment was 60. The sealer-based obturation group showed higher success rate than the continuous wave of condensation group, but the difference was not significant. Many factors affect the outcome of non-surgical root canal treatment, and root canal sealer is not known to be a significant factor. The sealer extrusion was found to be one of the two possible factors in the multivariate regression analysis that affect the outcome. Also, the post-operative pain after root canal obturation significantly reduced the success rate of the treatment. The voids were found to be insignificant to the outcome that was based on the both loose and strict criteria. As the last summary, using sealer-based obturation using endoseal can be a possible alternative to the continuous wave of condensation using the AH+. Before I finish, I want to show you this. This is named Masalat Hamrabi from my city, Babel. It was the first written human status legislation regulating the affairs of the life from my city. This is the name Masalat Hamrabi, and now it is in the Museum of Louvre in France.
Thank you very much, Ali. Thank you. You did a great job. Thank you very much. So we are going to end our sessions by saying a big appreciation to Dr. Ali Monir Sahib from Iraq by giving us this very good presentation because he did actually a very difficult job by reading this very nice article, very difficult article, obviously, to absorb, and he did a very important and very good job. Thank you very much, Ali, for that. So we are going to put our hand together for Ali and send our appreciation and this certificate, which is signed by Professor Ayati, the Vice Chancellor of Tehran University of Medical Sciences, and Professor Henry Kim, the President of Asian Pacific Endodontic Society, and Professor Sanjay Miglani, the Chief of the Education Committee of APEC, and myself. Thank you very much, Ali. We put our hand together for you for your presentation. And then we are going to say our huge thanks to Professor Jung to tolerate our difficult questions, our very harsh questions. This is the nature of this platform. Sorry about that. And I'm very happy to have you and for your tolerance. Thank you very much. And again, we put our hand together for Professor Jung, the President of Korean Endodontic Academy. Thank you very much, Professor Jung, and hope to see you in our future program as well. Thank you very much. And then we
Thank you for your interest.
Thank you.
Thank you for your interest.
Thank you. And obviously, this type of discussion may increase the number of citations to your article in the future as well.
Thank you very much.
Dr. John.
Thank you very much for your interest in our research. And because of my bad English, I'm afraid that I cannot provide enough information or accurate explanation. I'm very sorry. Next time,
don't say that. You did a great job.
Email,
you did a great
I
can
provide more information to you. Sorry about that.
No, don't say that. You did a very great job. Thank you very much indeed. Thanks a lot. And then we have Dr. Choi with us. That I'm sure, Dr. Jung, you want actually to say something about Dr. Choi and his job as well about this research. What do you think? Does he did a great job for you, for helping you for this study?
Yeah, I feel like I got a good coaching from great teachers. And also I'm very happy to know this study club, and I hope to join again as an offender, not a defender.
Yeah. Yes, definitely. Please be ready for that. And we put our hand together for you. Okay, usually we finish our work and our sessions by having some word from our president. Professor Henry Kim, please go ahead and give us your last words. And we end up our sessions by showing the videos after Professor Kim talk. Professor Kim, the stage is yours.
Yes, it's already 11:40 p.m. in Korea, so we have to close as soon as possible. So I should say, Professor Jung, the president of Korean Academy of Endo. So thank you very much, Professor Jung and Dr. Cho also. It's good to have you here in this platform. As Dr. Cho said, it's very hard place. So you did a great job. So I'm so happy to see you here again. So all the participants, we hope to see you again, and we may talk further in detail about not only this article, we have to talk again for the cellular-based technique. That is quite new technique, so we may talk in the future further. Thank you very much for all your participation.
Thank you very much, Professor Henry Kim. And we have a lot of appreciation and thanks to Dr. Cho and Professor Jung for being with us and discussing the prestigious article. This is a very difficult to do such a job, and obviously we need a lot of evidence in endodontics. Unfortunately, endodontics is a part of the science that we don't have enough evidence for our clinical job. Thank you very much, everybody, and have a very good night and very good evening everywhere in the world. Professor Al-Hawezi and others, thank you very much. We end up our session by showing some video from our sponsor. Goodbye.
Bye.
Bye.
Okay, thank you. you.